Welcome, everyone. My name is Samir Kakodkar. I'm a gastroenterologist and specialist in ulcerative colitis and Crohn's disease. Welcome to Against the Grain. Please do check out the rest of my podcasts, which can be found at the website samir3.podomatic.com. It can also be found on YouTube or Spotify by searching my first and last name. For those who are interested in contacting me regarding questions or for virtual appointments, my email is samir3@gmail.com. On Facebook, you can search Against the Grain to join the private group where there are ongoing discussions about these podcasts. All right, so I'm back. It's been somewhat of a hiatus, but I'm back here with Andrew Kornfeld and Amy Loftus, both of IBDCoach. And if you've listened to my previous episodes, you know Andrew and I did an episode, what was that, like a year ago?
2 years ago.
2 years ago.
2 years ago.
Very well received, and we did that one in the hospital. Now we're in my townhouse, and although it's the COVID pandemic, we're all vaccinated, not wearing masks, so we're all feeling safe and good. How are you guys doing?
We're doing amazing. Yeah, it's great to be here. It's great to be able to be here in person again with you. My entire family lives in Evanston right here, so their part of me does feel at home in the Midwest. I'm a Californian, true at heart, but it's great to be here.
Yeah.
Oh, really glad to be here, too. Yeah. I actually was born in the Midwest, so this feels like coming home in some respects, but that humidity
cool.
We love so much.
Where are you originally from, then?
So I was born in Minnesota, and then my family bounced around and landed in California about 20 years ago.
Okay.
Yeah.
And for the people listening who may not have heard the initial episode, can you briefly just go through what your role is and
Sure.
what IBDCoach is?
Yeah, and I'll tell you a little bit about our background, too. Amy has a very relevant background here to what we do. So my name's Andrew. I have been diagnosed with Crohn's disease. I was diagnosed when I was about 16. Pretty severe case. Really worked for a long time to overcome it. I studied neuroscience and psychology at the University of California. Again, have used kind of that background in thinking and feeling and the brain to inform what we do now. My role, I started IBDCoach in 2019. I think we were about 4 or 5 months into it, or not, barely 4 months into it when we first recorded the podcast, and we have come a long way here. I think there were just under 10 people in the program. Now there's almost 100 people in the program. I think the initial indications of the kind of special approach that we have, they were very positive, but they weren't set in stone or anything like that, and they're certainly not now. But the results have kind of blown us out of the water. They've been very humbling. They truly are kind of like our wildest dreams are coming true right now, and to see the stories of people who have completely changed their life. Some people have suffered for over 10 years, tried every medication, tried every diet, tried everything, have given up. They've been able to join our community, join our program, what we do, and they have really changed their own life. We've helped to inspire them and helped to teach them many things. So my job is I coach the clients in the program, and we'll talk a little bit more about how we are redefining health coaching. It's not a traditional form of me making recommendations like a doctor or anything like that. It's a much more nuanced process than that, and really helping them to understand biology, to help them understand all of these different multidimensional factors that are coming into their disease, navigating the healthcare system, working with their GI doctors, working with dietitians and nutritionists, and helping them to understand how to integrate all those recommendations together, even those from if they decide to pursue complementary practices and things like that, and understanding maybe the difference between what might be more evidence-based and what's not. And we really work to do that. I run the day-to-day of the company in a lot of ways, it's been an adventure for sure. I'll just say real quick before you introduce yourself, I mean, starting IBDCoach, I think most people, in starting a company with the type of vision we have, they would have sought out funding. They would have gotten a couple $1 million at least in the bank. We decided not to do that. We decided to just start with nothing, build it from scratch, build a product, sell the product, see if it's working. And we still have not, needed funding or anything like that. And we are running, very privileged to be running a successful business, but something that also makes a difference in people's lives. And our ongoing goal is to make it as accessible as possible to as many people across the economic, socio-spectrum as possible. Socio-economic. Cool. Amy.
So I came to IBDCoach only about 9 months ago. So Andrew had been running it without me, essentially, up until that point. And before that, I come to IBDCoach with a background in middle school teaching. I was a 6th grade science and other subjects teacher for 3 years. Taught music before then, and then moved from teaching into software engineering. Worked at a tech company that specializes in the health insurance space. So I have that combination of education experience and health and medicine, and bring that to IBDCoach. So I quit my job at the tech company about a year ago and was able to join up with Andrew and really help things scale in the last 9 months, especially. So I run the operations arm. I make sure that everything gets done on time, and I also do a lot of nourishment of our community and the broader community, including the family members and loved ones of people who are members in our program, because we believe that IBD is a family affair. And not having IBD myself definitely gives me a perspective of how much I have come to learn this condition, but also how limited my experience will be in ever living it firsthand. And so providing support for the parents of people and the spouses of other people in our program is really important to me, to continue to support all of these people in their journeys to remission.
Cool. Thanks for making it out here. I think it's really interesting to talk to you guys, because especially when you hear people who have Crohn's, who are involved in helping patients with Crohn's get through that process, I think you get more real information. You can listen to a lot of conferences put on by people who may have a conflict of interest regarding, being on a pharmaceutical company's board of directors, and they have a certain interest in pushing pharmaceutical medications, and that is part of what I do in my job is prescribe medication. But I take pride in saying that I don't take any money from any pharmaceutical companies. I try to be as unbiased as I can. And just as a disclaimer regarding this podcast, Andrew did reach out to me, interested in sharing some of the things he's learned since the last podcast, and I'm always open to learning new things. But there's no financial relationship between us, none at all. We do have a couple patients in common that we follow, but other than that, I'm here just to learn and see what he's learned over the last couple of years, in case there's something that I may not know. So let's start from there. Since the last podcast, what are some things, having interviewed and having guided now over 100 patients through this process, through your program, what are some things we are potentially missing in Western medicine in treating IBD patients?
Sure. So in our program, we don't consider them patients. We consider them members. I think almost the term patient, right, it implies that there's a dependency on the healthcare system, that this person is patiently waiting for someone else to come in and save them. And I think the biggest thing that we've learned is that we set out a hypothesis in the beginning. We said, what if it's possible for us? What happens instead of only using these incredible life-saving medications, these biologics? They're miracles that we have these drugs that are there. Sure, they're not perfect. Sure, they can have side effects sometimes. instead of only using these biologics, or on the other hand, using these insane elimination diets, that, we get people who are like only eating fruit or something like that. It's just absolutely
limited to like 3 foods.
Yeah, it's absolute. They're underweight, they're malnutrition. It's pretty crazy. Is there a different way? How can we? Our hypothesis essentially when we came on the podcast was, hey, how can we look at the biology of this condition? How can we understand what's going on? How can we look at the way that nature works? How can we look at ecological systems? And how can we apply that to a very complex problem like inflammatory bowel disease? Yeah, I think one person that has informed our thinking and our thought process, actually, my dad introduced me to this person. It's someone that inspires his work. My dad is a psychopharmacologist. So both Amy and me come from a very medical family. Amy's father is a vascular surgeon at Mayo Clinic. So, he said he's a systems thinker, and he's thought of, problems in complex ways. And we can't just essentially, have perhaps one approach here. We need a multidimensional approach. And he said, the major Gregory Bateson, he was an anthropologist. He was what we call a cyberneticist early in the day. He was a professor at the University of California. He was actually married to Margaret Mead, who was an anthropologist. He came from a very, biologically attuned family. His father was named William Bateson, who was actually the rediscoverer of Gregor Mendel's work, and he actually coined the term genetics. So he came from this very, biologically robust family, and he said, the major problems in the world are the result of the difference between the way nature works and the way people think. And with IBD, what we see is that we are not potentially thinking about this problem correctly. We're thinking of it in a very linear way, that there's going to be a silver bullet, that silver bullet is going to be infliximab or some other biologic, or even on the other side, that the silver bullet is going to be diet, only diet. Mm-hmm. And what we find is there's just a numerous amount of factors. And I think the biggest thing we've learned, since, is that's more true than ever. And, I think, like I said, I think we had some, very initial promising results when we recorded that podcast, but it was ultimately too early, and that this is an enormous healing process. And we asked ourselves, hey, what would happen if we inspire the human being at the center? What if we teach them? What if we help them understand biology? What if we help them understand the mechanisms of their medications? What if we help them understand the mechanism of certain supplements and herbs they're taking? What if we help them understand how diet might be working? And then to go through a very strategic trial and error process to see what's working and what's not. Mm-hmm. And at the end of the day, there's no allergy test, there's no calprotectin test, there's no test that's going to tell us exactly what to do. At the end of the day, each IBD patient needs to become more powerful and gain that courage in order to figure out what's working for them and what's not.
So let's drill more into diet, because that's a huge question. Probably amongst most of my listeners find me because they Google some diet, like the specific carbohydrate diet, or the IBD-AID diet, or the whole food plant-based diet. There's a lot of diets out there. I've posted on my social media that my opinion about this stuff is that I've really studied over the years the commonalities between these diets, and pretty much they all take out processed food, and they tend to be plant-based. Not always, but you tend to eat more plants, more varieties of fiber when you follow these protocols, even though not all of them are completely vegan or take out animal products. Like, for example, the SCD, a lot of meat and dairy potentially could be included in that, lactose-free dairy. So from your perspective, what are your current thoughts? I know you have a new framework in the way you think about diet, so can you talk about that a little bit?
Sure. So, look, we've seen all these diets. We've seen the specific carbohydrate diet. We've seen IBD-AID, which comes from the University of Massachusetts. You had a podcast on that. Mm-hmm. There's AIP, it's based off paleo, and they're very similar in a lot of ways. They do all take out processed foods. there's something going on with complex carbohydrates. That's clear. We know that complex carbohydrates feed the microbiome, and there's certain starches are probably feeding non-beneficial microbes, whereas fiber and resistant starch and these things are probably, feeding more important microbes. But what we find is that, people see these lists of legal and illegal. And actually what we find, I know this might be a little different from your perspective, but that our food tolerances change. Okay, we can't just have a static list. And even IBD-AID, which is good, it has these 3 different phases, and it incorporates blending foods, which is very, very important. What we see is that people can then tolerate more foods as they heal. They can oftentimes they need to listen to their body, because even a food that they were tolerating, they need to be able to maybe take that out if it is bothering them. So we have the adaptive dietary framework. We have 3 different domains similar to IBD-AID. They call them phases. We call them domains because that's a little bit more of an incorporating term in our opinion. There's a foundational domain, there's a stability domain, and there's an exploratory domain. So there's no such thing as cheating at IBDCoach. We call it exploring. So if someone wants to go try a new food, and Amy is always reminding me, when I comes out, I think I'm gonna, go, cheat a little bit. Nope, we don't use that word.
It's a food adventure.
It's a food adventure. We're gonna go on a food adventure today, and so people come in the foundational domain, and we pick a dietary strategy. We educate them on SCD, IBD-AID, and we show them the pros and cons of the different strategies. Okay, like the pro of SCD is that it's been around for a long time. Something is clearly working very well. Maybe there's too many animal products that are included on that. Maybe there's not enough focus on actually feeding the microbiome. Maybe the disadvantage of IBD-AID is that there's this introduction of sweet potatoes and oats right away, and that seems like kind of jumping the gun a little bit sometimes for a lot of people. But then the advantage of IBD-AID is that there's these 3 phases, and that people can blend things, and then there's like AIP, and there's many other diets like Mediterranean, but maybe AIP is not so helpful because they just kind of blatantly cut out all of these things for autoimmune conditions. And I don't know if this is your understanding, but we are starting to learn that IBD is clearly not a traditional autoimmune condition. It's not there's not antibodies against actual tissue, right? It's against probably microorganisms and food particles that are leaking into the lamina propria. So we start with this, and then we go through. We see they kind of a lot of members have a general idea. So we start them off in the foundational domain, and then we start a very strategic trial and error process, introducing things, taking things away with them, and they're working in this framework with their nutritionist, with their dietitian. We often encourage them to show this in what's called the Remission Master Plan, which is really one of the cornerstones of their program, to their GI doctor. A lot of this, our clients tell us that this Remission Master Plan has been a game changer in communicating with their doctor, because all of a sudden their doctor is able to see everything that they're doing right there, and we're trying to lubricate this relationship with the healthcare system that they're having. And they move through these different domains. Some people come into the program and they're eating everything. They're eating cheeseburgers. They're eating, all sorts of things. Some people come to the program, they're eating 3 foods. And usually what we find is that, someone who's eating 3 foods, you got to just start introducing things more.
Right.
But we can't, diet is not everything here. And what we are seeing in our clients is that if inflammation is too high, you're not going to be able to calm this down with just diet or lifestyle. There does need to usually be some sort of intervention that's going to calm down the immune system a little bit in order to allow diet to work. And I'll just comment on the plant-based animal product thing. Look, there's a lot of this is like the hottest topic. It's the most controversial topic in everything. There's so many feelings around this. There's ethical issues that go into this. We don't really know. We're about to attend the Ancestral Health Conference. I guarantee you, there's not a plant-based person that's going to be at this conference. And it's pretty evident that our ancestors did eat animal products. That's a huge. It's unheard of to find a culture that didn't include animal products in their diet, and they're very nutrient-dense foods. Does that mean that like red meat is not inflammatory or eggs are not inflammatory? No. It means that these things can be inflammatory. We find that when someone's like totally plant-based, they come into our program, we often encourage them to get out of their comfort zone and maybe start to incorporate very carefully, very slowly, some animal products. Maybe they'll just start to sip a little bit of bone broth, like one sip, a little bit of salmon, something like that. Someone who comes into our program who's like a carnivore, we get that. If people are like ketogenic or they're carnivore, we really encourage them to eat a little bit more, try eating a little bit more plants. But at the end of the day, it doesn't matter as much as you would think. Really, it matters what they believe. And if someone is 100% convinced that red meat is the worst thing in the world, we can't push that. And it needs to be a process.
I mean, there's such a tendency that we see in folks with any type of GI disorder to once they find a food that works for them, they stick with it and they go hard on it, sometimes at the expense of other varieties of foods or other diversities of foods. And so then when that food doesn't work anymore, because at some point something else changes in the environment and then that food causes issues, then it can be sort of a disrupting emotional experience too. And so we try to expand the understanding of food of, like, our adapted dietary framework considers not just the food itself, but is it cooked? What texture is it? How much of it are you eating? Small amounts of some slightly more inflammatory foods may just not hit that threshold for some folks to cause issues.
I do agree with you that I think one of the main controversies in the dietary landscape of IBD is the whole thing about meat and dairy. The specific carbohydrate diet is kind of this old school diet where really even the way it starts is pretty meat and dairy heavy, and that's really unlimited. You can get as much meat and lactose-free dairy that you want in the diet. But now these more and more of these scientific publications, books being published in the lay press about what's the best diet, not just for IBD, but digestive health in general, seems to be more plant-based. And there's a really popular book that I actually recommend to a lot of my patients called Fiber Field, which kind of goes over a lot of this. But I'm more of a person that I believe in reality, not mechanisms necessarily. Just because a food theoretically like meat can cause inflammation because it leads to more hydrogen sulfide production that inhibits beta oxidation of short chain fatty acids. But at the same time, that's another big one. But that's on one side. But on the other side, if you have a patient in front of you who says, I don't have any issues eating meat, and you do a colonoscopy and it's like completely normal with mucosal healing, what am I going to say? Like, oh, stop eating meat. Another thing that I do is, like you said, like you kind of have to see the patient, and if they're not doing well, whatever dietary pattern that they're following at that moment may not be the best for them. So if they're eating a heavy meat diet and they have Crohn's and they're in bad shape and they're asking for dietary advice, what do I do? It probably makes sense for that person to go plant-based or vice versa. So I think it's not as simple as just a blanket statement that every IBD patient has to be vegan and that's the best way to go. And oftentimes I feel like sometimes people who make these statements don't have IBD themselves, and it's different. Like it is, and it's also tempting to stick with a few foods that you feel are safe, especially. And I've fallen into that trap myself, where I've eaten pretty much the same thing for months on end, just because like I have a busy job and I have to work multiple hours, sometimes night calls, and I don't have much time to explore and try to eat things and risk not feeling well the next day. Mm-hmm. So it's tempting, but theoretically, if you have more of a diverse diet, it's going to lead to more microbiome diversity. Another thing I brought up on my Facebook group, which I know you guys are part of, and other people who are listening, is I do think there is a value to being low carb sometimes, or relatively low carb in the context of Crohn's. The reason I say that is I have seen many patients, like when I did that case series on the specific carbohydrate diet, it was mostly Crohn's patients who responded to that. I found very few ulcerative colitis patients who, and in my clinical practice, I've had patients with severe UC where I've tried to put them on something like the specific carbohydrate diet and they got worse. So my practice nowadays is if someone has Crohn's, I tell them their starting point should be either STD or IBD-AID. And if they have ulcerative colitis, probably starting with whole food plant-based. I feel like there's better success, and then from there it's a learning process and tailoring it.
I would agree with you that I think the meat sensitivity is higher in ulcerative colitis patients. For whatever reason, that's probably true. But I think the total exclusion of animal products, I think people can thrive on a plant-based diet. I think the total exclusion of either plants or animals in a diet is probably not that wise. Probably for most people.
The exception, not the rule.
It's the exception. And, for those people who are plant-based, that's awesome. Power to you. And if you're doing really well on a plant-based diet, then you should stick with it.
Yeah.
I'm going to bring up some research. I wish Lucy was here right now. Lucy Mailing, she's a close friend of ours. She's one of our science advisors. She's really I consider her one of the world's experts on the microbiome. She's really pushing this kind of narrative that fiber is the only way to feed the microbiome, that there's a lot of different ways. We know that polyphenols and flavonoids feed the microbiome too, but it's probably mainly plants. Look, she's tested multiple carnivores. They have the most diverse microbiomes she's ever seen. What's going on there? What's happening there? These people are doing really well on only, these are not necessarily IBD patients. I do not, and I've spoken with many, there's not anyone in our program right now that's carnivore, and that would make me a little bit uncomfortable, but I have met multiple people with IBD who are literally only eating animal products, and they report that they're doing really, really well.
Right.
So how do we reconcile that? Do we tell them that they're wrong? What is going on there?
And I think this is another issue with theory over reality, in that, so we know IBD patients have a less diverse microbiome compared to normal. Does that mean increasing the diversity of the microbiome, particularly, for example, in Crohn's patients, will actually make them feel better? Nobody has really proved that to be the case. I did a case series on the specific carbohydrate diet that showed that they did have an increased microbiome diversity according to certain measures. But there's also evidence that certain interventions for Crohn's, like exclusive enteral nutrition, antibiotics that decrease the diversity of the microbiome, make Crohn's patients better and are associated with even healing of the colon in the case of exclusive enteral nutrition, which means drinking pretty much formula exclusively. So I think we're making a jump by saying, normalizing the microbiome or making it extremely diverse. I feel like that's helpful in ulcerative colitis. It may not be helpful in all of Crohn's patients. But again, there are exceptions to this. I mean, there are case reports of Crohn's patients healing on plant-based diets, as well as the whole Dr. Chiba, he's a Japanese gastroenterologist who implemented this plant-based diet, and that tended to work for Crohn's patients in combination with medication. But his diet had had unlimited eggs and milk and yogurt as well, so it was not necessarily a vegan diet.
Yeah, and at the end of the day, what we are, the bottom line that we approach this with is it's about cultivating that internal intuition in our members to be able to look at a food, maybe even taste it, and to feel in their bodies, is this right for me at this time, right now? And Andrew will freely say that the development of good boundaries, good social boundaries around food etiquette, for him, they look a little bit different than everyone else, and he will not put a food in his body that isn't going to be good for him. And I'm really proud of him for that.
Well, can you comment a little bit on do you coach your clients on following it? Like for a lot of people, following diets like this can be traumatic, can be socially isolating, can cause issues itself. So is there any kind of advice you can give people regarding that?
I think we need to just throw out the word compliance. Let's just throw that out. Let's just get that out of our vocabulary, and let's also get the word, Amy constantly reminds us, let's get the word cheating out of our vocabulary. Food is food, okay? And
it's morally neutral.
And the idea right now, I could eat just about anything, and I would be fine. One time, no problem. As long as I'll never eat fast food. I'll never eat processed food. But if I want to eat maybe a little bit of pizza, really high quality pizza, I'm fine. It's not a huge issue. And that probably has to do with again, feeding, the microbiome and just making sure that things are in check there. I think that, again, we need to go back to the fact that there is no test that anyone can do here to figure out diet. And we need to just come to terms that there's no perfectly objective way to do this. And that we need to help clients surround them in an immersive and nurturing environment to allow them to not feel traumatized by food and to not be afraid, of food in so many ways. And we find that that's really, really important.
Mm-hmm. We have one really interesting case of a family that we enrolled. So the individual with Crohn's is under 18, and that navigating that social space of how do you coach your kid on how to move about the world and be able to say no, say yes, and explain their condition to their friends while they're navigating all these other aspects of growing up.
Right.
And so we really watched this individual blossom over the course of the last few months and really come into themselves in order to attend a summer camp where there is all kinds of food issues happening. I think the resolution was being prepared and coaching this person with a script of, here's what you can say to someone if they offer you food that you don't want to eat. You say, no, thank you. I don't want that right now. Can I have something else instead?
Yeah.
And sometimes it's as simple as giving people the words to do that and giving this person permission to move through the world and exert their boundaries.
Right. I think one of the benefits of doing medication along with diet, nowadays I get a lot of patients who actually come to see me from the podcast, some patients we have in common, that ask me about diet. It pretty much is always a question. And they ask me, what is the success rate? Have you actually seen people do well with it? And I'm just telling you the truth here. It's not like I have any kind of necessarily a reason to be biased one way or another. But I really feel like it's the minority of patients who are able to maintain remission, get into mucosal healing just with diet, without the assistance of medication. I did plenty of podcasts on people who are able to do it, so it's not impossible. But I think it's a relatively fragile remission, and also most of those people don't have really objective evidence of being completely healed, which is even difficult to do with medications as well. So, my estimate as far as how often this happens is about 10%. That's based on my clinical judgment. It's not based on any studies, but of all the patients I've seen, and that's what I tell patients. I think you have a 10% shot. If you only want to do this with diet and nothing else, that's been my observation.
Not even prednisone or a steroid?
Yeah. For example, I can tell you I saw a patient recently who has had relatively mild Crohn's for over 10 years. It was detected incidentally on a screening colonoscopy 10 years ago. Didn't treat it at all. Mm-hmm. And then had another colonoscopy relatively recently with these kind of superficial aphthous ulcers in the ileum and colon. And following pretty much a Western diet, doing nothing, pretty much asymptomatic. So I told him, I was like, hey, you're not symptomatic, you haven't had any complications over the last 10 years, so that bodes pretty well. So I pretty much told him, you're on a meat-heavy diet, why not do whole food plant-based? And I actually told him to take curcumin as well along with it, and then we're going to, scope him in a year and see if things look different. But I think in those contexts of patients with relatively mild disease, low risk of progression, and they're feeling fine, I think dietary monotherapy makes sense. And at the same time, I've seen patients with severe disease turn it around. I did a podcast with Raman Prasad, who pretty much had disease needing colectomy, was on high doses of prednisone, and went on SCD and was med-free for years. So it's possible, but I think it's the minority of patients that are able to do it.
I would totally confirm that. The people who have made the most remarkable transformations, even the people who are now medication-free in our program, inflammation is so high in this, and it's a vicious cycle, kind of like the SCD, but it's the IBD vicious cycle. Just inflammation is so high, it's wrecking the barrier, right? And it's just like you gotta put a stick in the bicycle wheel to stop the inflammation before. And what our science advisor, Ali Arjaman, he's a strong believer in medications, even though all of them failed him. Yeah, we like to say that patients don't fail the medications fail the patients. We're very careful about how we speak, about this disease. And look, he says that, sometimes you're drowning, you're in the water, you're treading water. You need something to even get to the lifeboat, okay? And that might be prednisone. Some people don't respond to prednisone, and they do respond. We've seen people who have no response to prednisone. You give them Remicade, it's like night and day. And we fully see that, and we fully, believe in that. And then once the mucosal healing is there, they've implemented the foundations are there, they've implemented the dietary strategy, then talking about discontinuing the medications, I think, is a real conversations to have. And I think that's one really linear way that current medicine is looking at these meds. They don't look at them as tools, but they look at them as life sentences. I was told, almost every client in the program, every member was told that you're going to take this for the rest of your life, which is just not even true at all, because they might develop antibodies against it or whatever. But I think it's okay to use these even with the risk of developing antibodies, even with the data that says the biologic that you give first will work the best. I think we need to view these as tools, not life sentences. And that's going to, like you said, probably increase the probability that someone is willing to try a biologic or something to get them to the lifeboat. Diet and lifestyle and community, love, all the things that we need, nourishment as human beings, are going to allow that lifeboat to get to the island, get to shore, and then we can talk about really going more advanced and being able to even discontinue meds. And I just want to say this for the record, if anyone's listening to this, I am not on any biologic. I'm on mesalamine right now. I find it very helpful. I'm also on a small dose of bupropion. I find that very helpful. Kind of helps get it. I have a little bit of ADHD. It helps with that, just a little bit at all. It's all part of a system. In no way am I afraid to engage with a biologic. I would take Entyvio or Stelara or even Remicade or Humira if I needed to do that. And sometimes, I feel like it is a lot of work, sometimes. And just having that openness to that possibility, I think actually decreases the likelihood that I would ever need that. Just because I have that openness and I don't have a rigid form of that, I don't have a rigid mindset in that way.
Yeah. Yeah, I often get patients asking me, this is a very common question when I bring up the issue of medications, biologics. They ask, how long do I need to be on this, right? So my standard answer is usually, it's actually ideal if you were to be on it for a long time, because that means it's probably working and you're not having any side effects from it. But I also tell the patient, you're always in control. Like this, nobody's forcing this on you. I mean, you always have the final decision on if you make that call with the infusion center and schedule that appointment to get that infusion, or you call to get that shipment of the injectable. That's always up to you, but I can give that suggestion to you. Now, this whole thing about de-escalation of therapy, a lot of people get on biologics, they get on a diet, they may do a lot of lifestyle things, herbal treatments, etc., and they get to a good place. And then the question is what to do with the medication at that point. And there's some data to guide this. I've spoken about this in my previous podcast. You can listen to my one about diet and medication management. But ultimately, my experience on people in this context who have a normal colon and it looks good and we stop medicine is that most of them do well for some time. I would say most of the time it's several months. It can even go up to a few years. But it seems like whatever remission is achieved without after the medicine is stopped, for most people it tends to be short-lived, and a flare will happen at some point in the future. I wish I didn't have to say that, and I didn't used to believe that. I used to believe that diet potentially could sustain remission long-term without meds. And even there are some publications, including Dr. Chiba's publication, where he used just 3 doses of Remicade and then he had nearly 100% sustained remission after a year or two. But it seems like longer term, a flare is most likely going to happen, unfortunately. So that's what I've noticed. So what I tell patients now is, hey, if you're tolerating the medicine, you're not having any side effects at this point, I would just continue it. But ultimately, it's up to you. And if patients are willing to gamble, if they're feeling lucky, I don't have any issue with them stopping it, because especially with these newer meds like Entyvio and Stelara, restarting them associated with a very low rate of antibody production, and usually people recapture response.
So let's just throw out this term gambling. You know what I mean? Let's not gamble. Let's enroll patients who want to come off these meds. Let's not have them come off the meds right away. Let's have them enroll in our program or something like that. Let's have them learn about the biology of this condition. Let's have them learn the mechanisms of this disease. Let's have them make the remission master plan and make a very robust plan to come off this medication and a very robust plan to be off of it and go into it very, very intentionally. What we find is when that happens, the success is way, way higher. I would totally agree with you that most people who come off their biologics flare again. It's all the people that hit us up, and that's why I think our program is really a kind of a revolution in healthcare. It's like really, and it's not even healthcare. It's something that allows you to do your job better. How can we make sure that patients are more likely to not only comply with their medications, but respond better?
Sure.
And the foundation to that is a very, very robust and beautiful lifestyle protocol, and them creating the type of environment that they need, creating the home environment that they need, creating the work environment that they need. Everything. You can't just randomly come off the medication and hope for the best, or it's not going to go well.
Yeah, you really hit on 2 points that are super important to us. One, that the power is always in the patient, the person, to make choices about themselves. And what we're hoping to do, of course, is to arm them with the information about their biology, about the state of their body, to make that decision even more in a more informed capacity. And the second piece is that we know that IBD is a lifetime condition and that a flare will happen. We are not trying to avoid flares for the future of the entire rest of this person's life. But what we do find is that people who've gone through our program, when they flare again, because it will happen, they are better equipped to manage that flare and end it sooner. Mm-hmm. And we see that time and time again.
We've seen people who, we've had multiple people flare again in our program. And almost the people who are super serious about the program, which is most of the people in the program, the flare, instead of it lasting months on end and they're uncontrolled and they're depressed and they're anxious and they're having the PTSD type of symptoms from all the tests that they're getting and the contrast and the sticking with needles and everything, they're like, okay, I got this. Everything's written down right now in the remission master plan. I actually want to read you this. This is from a quote from one of our early members. She enrolled right after we enrolled a podcast. Her name's Haley. She actually, just full disclaimer, she works with us now as an admissions advisor. She's so encouraged by our team. She's a physical therapist. She had suffered with UC uncontrolled for 12 years. Maximum dose of Remicade, on a never-ending prednisone taper cycle. She used to hoard prednisone. She used to hide the prednisone. She used to tell her gastroenterologist she lost the prednisone. It was this really horrible relationship. And she was struggling. She says, my UC was really impacting my ability to work, my relationships, and my ability to get outside and enjoy doing the things I love. It also severely impacted my family because I was told that I was not in good enough health to have a baby. So, look, she fully embraced the program. She came into the program. She learned everything about her condition. She completed her remission master plan. She made a plan around this condition. And the remission master plan was really a game changer for her in her being able to communicate with her gastroenterologist. They ultimately decided to discontinue the Remicade as she implemented a lifestyle protocol. She says, I switched gastroenterologists at the beginning of this program so I could have a fresh start, and I sent the physician my remission master plan. She read it over before our initial appointment, and when it came in, it was a completely different experience than my medical appointments in the past. She had that inside look at me. She had everything in there that I felt were relevant things about my diet, about my stressors, about my living situations, and all of the medications and supplements and such that I had tried in the past. Those things don't all make it into your electronic medical records. So it felt very helpful to have all of that together and present it to her. When I came in, she had already read my goals. She had already read some of my action items, things that I wanted to discuss with her, and for the reasons why. We were able to have a very productive conversation and make good progress. The RMP was a lifeline between myself and medical team. Long story short, Haley is in clinical and symptomatic remission right now. For the first time in 12 years, she has a beautiful baby boy. She was on the, when we first had our admissions call, she cried on the phone with me and said, I don't think I'm ever going to have a family. And I said, I don't know, Haley. Mm-hmm. I think we can do this. It's the first time her husband has ever seen her, be able to do this. And she's off her medication. She's not on medication. She's on the Salamine. Again, she is very careful, about her diet. She understands this. And this is what we're talking about. This is, what if we, rather than having IBD patients be blind, what if we surround them with an amazing community, with love, with compassion? What if we surround them with science? What if we lubricate the relationships between the medical team members all in one place in the remission master plan? What happens? Well, this is what we're seeing, can happen and can occur here. And that is why we believe in the power of the environment, and how we need to think about this disease differently. And we need to think about how the environment, obviously the environment, there was a genetic predisposition. We know there's many causes to this condition, but there was some environmental trigger, to this condition. So, I think I get that the theory is not as important as reality, and we are totally in agreement, but you have to teach people what we know right now.
So can you I've actually seen your example of a remission master plan for yourself.
Sure.
And it's a pretty detailed, extensive document about everything you've tried, what you feel has worked for you, and kind of your dietary phases as far as. But for the people who are not familiar with it, who are learning about this term for the first time, at least the term you're using as part of your program, this remission master plan. Can you briefly explain what exactly is that?
Sure, I can speak to that. We think of the remission master plan as the workbook piece of homework that pairs along with the rest of our course and community. And so it's the one-stop shop for people to write down and record their entire IBD story all in one place, to identify their goals, give them a vision for looking forward, but then record and identify all the other pieces and components that are going into their whole life approach to achieving the remission goals that they want. Mm-hmm. So we have a section for the diet, we have a section for supplements and herbs, we have a section to even identify all of the different players in their health and medical team. So it's all in one place, so that when they can hand it over to their nutritionist is aware that they're working with a GI, that they're working with a therapist. We really view IBD as a complex problem that involves every facet of life, and so we try to get as much of that into this document as possible. And we also see it as a living document. So they go through it in the course of their overview of their course material, and then they continue to refine it and iterate on this. And Andrew still updates his on a regular basis as well as he continued to learn things about his body. So it being a resource not only for the person to, and I think one of our clients have express that the process of going through and filling out this document is valuable to have it all in one place, but also it really is much like flashcards when you're studying for a test. The process of going through it and that introspection and getting in touch with all these different pieces is immensely valuable.
Sure. Yeah,
I'll just say that, look, like, I talked about systems thinking, in this type of way. And in systems thinking, there's a lot of different components. And we believe in IBD that no one diet, no one medication, certainly no one supplement is going to be some sort of miracle cure. Mm-hmm. But it's also important for us to pay attention to the relationships between these variables. And, what we look at all of these different variables and you ask yourself, in the equation of IBD, and the interaction that this patient is having with the healthcare system, what's the most foundational, what is the most interconnected, interdependent variable here, that if we don't have this variable in place, the integrity of the system will break? It's the patient in the middle. It's the human being. And, it's tricky to pick one thing, but you say, what's one thing we can change by a human? What's foundational? What's the foundational component of the human system? Mm-hmm. Well, I am biased because I'm coming at this from a neuroscience and psychological perspective, but if we change the brain, we believe we're able to change behavior. And Amy, as a UC Berkeley education grad, as someone who has taught developing minds for a long time, that learning is very, very powerful in the process of going through that. So we believe that the remission master plan, the environment that they're in, is activating neuroplasticity undoubtedly. Mm-hmm. And that means we're not only, probably changing things on the synaptic level, but there's structural changes, there's new brain maps that are being formed, okay? And they're able to see connections that they've never been able to see before. They're putting this intention into this document. And just like Amy said, it's not that they're memorizing everything, it's the intention and it's the process that they're going through. And all of a sudden, they feel empowered. They know what to do, they've discovered new things, they understand new things, and they have designed their own protocol. Because, like you said, it doesn't matter. We can talk about mechanisms all day, mm-hmm. but what matters is what's working for the IBD patient, and they are able to find that special pattern that works for them by completing this document. And it's not something they complete in one day, okay? It's not something they complete in a week. They work on this document for months, and we ask them to look at it like the most important creative project they've ever done in their life. Mm-hmm. And just to look at it as something fun that they do, maybe like every evening for 20 minutes or something like that, and then they finish. And then they complete their adaptive dietary framework, and then they maybe update it every week, for 5 minutes. It takes 5 minutes to update this document. And in Google Documents, their GI doctors, their nutritionists, they're able to see the changes that happen in live time. And this is one way, this is again like this missing component of healthcare, essentially being able to bridge the discrepancy between communication between different healthcare professionals and the human being at the center.
Yeah. No, I do think there is value to that. I remember since I was diagnosed several years ago, I was doing something like this, but I was like keeping a blog. I actually started the day I started this specific carbohydrate diet, I think back in 2008 or so. And it was all like, initially I was doing it every day, like updating it, saying like, this is what I ate today, this is how I feel, these are my symptoms. And then day by day, and every kind of new thing that happened, new medication, I would record it there. But it was kind of disorganized. But I do look back at it often, and it is very helpful to look back and see, oh yeah, like 5 years ago I did try this for this particular symptom and it didn't work. And I feel like that information is relatively consistent, even if it was several years ago. Whatever you tried for a particular problem can potentially work for you again. And as IBD patients, we tend to try many things over the years. And most of them, in my experience, did not work. But there can be a few things that work for certain symptoms that you have that you kind of collect and keep on hand in case things go south. But another comment I had about you mentioned PTSD, and this has been kind of one of the things I've been looking into a lot myself. And the shout out to Raman Prasad. He told me to look into this book called The Body Keeps the Score. It's this. Have you guys heard of this book?
I just finished it. The other week, yeah.
I'm like halfway through it. That and also I'm using this Curable app on my phone, just kind of like learning a lot about this. But I think it really does apply not just to combat veterans and victims of sexual abuse, but I think having IBD itself is a major reason people can develop PTSD. I think all of us probably have some degree of it. And the reason for that is because we're put into a situation which we perceive as a threat to our well-being, a threat to our life, and we feel like we can't escape it. It's especially when treatments don't work and you're not getting any success, and that process of feeling almost like trapped, like you can't get out of this situation, can have long-standing psychological problems that can. And I do think that's a reason sometimes people flare, even when you get off biologics. That fear of flaring can actually bring on the flare itself. Even though some of the data is conflicting regarding if stress, anxiety can actually bring on a flare, I believe it does. For certain patients, that fear, and I see it all the time, patients want to get off biologics, but as soon as they do, that fear cycle starts getting in their brain, like, oh, when is it going to happen? Any little symptom, suddenly they're like freaked out, and maybe that can, start this cascade going as well.
And what if they had a plan? What if they had all of these other interventions that they had seen improvement with, that they had seen improvement with other people? If this happens, I'm going to do X, Y, Z. If I feel a little bit of, if I come off the biologics, I'm going to use a little bit of prednisone, which I actually really want to talk to you a little bit more about.
Sure.
Prednisone later on. Look, I actually wrote my undergraduate thesis on post-traumatic stress disorder. It's something that's very close to my heart. Look, we don't even have to pretend that this is just like hocus pocus. There's clearly an immune system involvement, with post-traumatic stress disorder.
Yeah.
We know that when someone is in a fight or flight situation, there's a lot of stress hormones that are being released. Mm-hmm. Right? There's cortisol, there's epinephrine, norepinephrine, these types of things. And my kind of rudimentary understanding right now, racking my brain, so please correct me if anything's wrong, but we are diverting in those moments where we're feeling that kind of increased heart rate, that anxiety. We're diverting resources away from systems of the body that we wouldn't necessarily need in a fight or flight situation. What are those systems of the body? They're the digestive. We don't really need to be digesting our food if we're trying to run away from a bear, right?
Right.
We don't really need to be regulating the immune system that much. That's probably why cortisol regulates the immune system, in this way. So when we get into these fight or flight situations, we're potentially inflaming the immune system a little bit as well. And we also see with post-traumatic stress disorder, there are brain changes that, that happens. Neurons not necessarily dying, but we see there's less dendrites and less connections, in people with PTSD. And that's why we see these memory, issues that are arising, and all of these multidimensional factors that are arising when human beings go through a very traumatic event. You were going to say something.
Yeah, we know that rates of medical PTSD as its own sort of category or type of PTSD are higher in people with IBD, and we just did a post on that a couple of months ago. But my biggest takeaway from that book, and another book that I'm actually starting to read, is Gabor Mate's When the Body Says No. It feels very relevant.
Yeah, I've read that one a long time ago.
My biggest takeaway from The Body Keeps the Score was just that the brain gets stuck, that feeling of stuck and trappedness, but the brain is neurologically doing that and is replaying the sequence of trauma over and over and over, and it cannot necessarily tell that is a past experience or something that isn't in the lived now. And it makes a lot of sense. Like, I'm not speaking from personal experience with IBD per se, but when the body becomes a source of pain, when food becomes a source of pain, it totally makes sense for the brain to store that memory in with the wiring just a little bit off, we'll say. Mm-hmm. And so we are looking to continue to develop our curriculum and our materials and supports to be more trauma-informed, we'll call it. And so we're looking at some guest speakers that we can bring on to speak to that, in particular in ways of addressing this foundational component.
Cool. Yeah, there's a lot of fear amongst not just IBD. I mean, I see a lot of patients who have irritable bowel syndrome, and I think it is difficult as a patient with any GI disorder or really any medical condition to not have a medical background, to not understand what's actually going on, so that you can freak out with like really any symptom because you don't really know what it could represent. I mean, you may have family members who've died of some sort of GI cancer, so your mind immediately jumps to like the worst scenario, and that itself can create symptoms. Like it can perpetuate this cycle where your brain is creating the pain rather than really having an organic cause to it. So we went over that. Anything else like that you've learned as far? I know this is kind of like a total package thing. Like it's not one thing that's going to make a major difference. It's more like everything in combination. But have there been like supplements, or I know you guys are into herbal teas. I've been kind of getting on that train as well. Just things that some people can try that you think may be generally helpful. Supplements, teas.
Sure. And I'm reluctant to even, you know what I mean? I want to go there, you know what I mean, in a lot of ways. I think there are just so many like multidimensional factors that we are finding. I think we got to just actually like back up though before we go there. 1 second. I want to know your understanding actually of the mechanism of IBD, and just kind of, because everything that we do, yes, we do base it off the mechanism, off the theory, you know, of what's going on.
Right.
Nothing, and we feel that is really important, especially for patients to understand that. So we have three. So my understanding, and I think this is evolving, and let me make sure it's the same as your understanding, is that there's some sort of genetic predisposition. There's that NOD2 gene in Crohn's disease. There's mutations in IL-10. There's mutations or single nucleotide polymorphisms in the tight junction proteins. And then there's some sort of leakage of microbial organisms. There's some sort of barrier disruption, and there's some sort of leakage across this first layer of cells. And then because the bacterial organisms are in sort of the wrong location, right? They're in this place called the lamina propria. There's an immune reaction to it, and that causes the inflammation. Is that the current understanding, you being at the top of your field, is that your understanding of the mechanism right now?
Yeah, I think that's generally correct. I have done a lot. I've spent a lot of time thinking about what causes it, and it is a bulk of the appointments I have with patients who have a new diagnosis explaining what's going on. I don't think there's... I think this is obvious to most people by now, but for each patient, it's probably a different mix of inputs that lead to this diagnosis of Crohn's. And what those could be for each individual patient may be different, but I kind of just lined them all up as far as what I think are major contributors. Genetic predisposition is one, but I would say even now, most of the patients that have new diagnoses don't have any family members who have it. It's now being diagnosed all over the world. There's like literally no population that's been spared from this. So I don't think the genetics, there's over 200 genes that have been at least associated with diagnosis of IBD.
Yeah.
I don't think it's a major thing. I think in certain cases, especially when very young kids are diagnosed, like in infancy, there's probably like a strong genetic component, but most adults that are diagnosed, I don't think genetics is a very important contributor.
Yeah, and I couldn't agree with you more. But so before I go into, I have a list. I'll read off some of the things that I think are really hard hitting for people, because I want to give that to people. But we base the program off the biology, and I was inspired by Michael Briggs. I was inspired by a lot of different people. What's like a 3-step process that we can always think that addresses this mechanism that we know. So the first step is stop the inflammation. You have to stop the inflammation. And look, the most powerful tool we probably have to like temporarily stop that inflammation is probably prednisone for most people. And that's just biologics. But there's a lot of different herbs that we can use in there. Curcumin, boswellia, ginger. There's different foods and teas, whether it's blueberry, green teas, packed with different flavonoids. Yeah, it's EEGC. I'm forgetting the name of it. There was quite a bit of research with UC. There's this guy, I think, at the University of Louisville. He's a GI doctor. He published this like huge thesis on using green tea in IBD. It was pretty impressive. It was very mainstream looking guy here. Different things like fasting, lifestyle, exercise, meditation, even maybe vagal nerve stimulation might reduce the inflammation. So that's really the first. You have to stop the inflammation. If you don't stop the inflammation, I think your feats are kind of futile. And I'm not saying that in 100% of the cases you need a medication, but I do want to talk a little bit more about prednisone because I think we're using prednisone wrong. And I'm a little bit out of my wheelhouse here to say that, but I'm never making this type of statement to. I'm never making recommendations or anything like that to our clients.
Okay.
I'll speak to that. Well, let me go through the other steps, and then let me get your feedback on that, and then we'll talk about prednisone just a tad. So then the second one is to nourish the microbiome. We know that there's some involvement of the microbiome. It's really unclear what we do, but we know that there are many. Interventions we can take that alter the microbiome potentially in a positive way, that move the microbiome in a way that we see in healthy controls, right? So, sure, probiotics. I'm not a huge fan of probiotics sometimes. They seem pretty like Pandora's box with people. Lucy's really big on being let's not shoot in the dark with probiotics. Let's be sure that if you're going to use a probiotic, that you use the one with the most science behind it. And that goes down to not only the species level, but the strain. Bacillus coagulans is not the same as a different Bacillus coagulans, or these different types of, one of the examples being E. coli can be really detrimental in Crohn's, but this probiotic E. coli Nissel 1917 has been highly studied. Very difficult probiotic to get by the hand, and it's packed with maltodextrin and all these other binders. Mm-hmm. So different ways we nourish the microbiome: probiotic foods, probiotic supplements, kimchi, miso, sauerkraut, kefir, fermentable fibers that are blended, blueberries, things like avocados, maybe sunchoke, squash, even mushrooms, maybe oats, maybe probably not in the beginning. Fecal microbial transplants still under investigation. Probably more. We talked to a clinic in the UK, very interesting people there at the Taymount Clinic. They basically told us in one way or the other, we kind of read through the lines, that they don't have any success with Crohn's disease, some success with ulcerative colitis. And even medications. We know that 5-ASAs even influence the microbiome in a positive way. Lucy has reported multiple times that her IBD clients who are on 5-ASAs, their microbiomes look a little bit better. Lifestyle, sleep, exercise, meditation. Even Ali says that his microbiome got way more diverse when he was in Tokyo, and he was around all of these people all the time, and he was constantly testing it. So again, stop the inflammation, step 1. Step 2, nourish the microbiome. Step 3, you got to repair that barrier. We got to figure, I think, and repairing the barrier is the most nebulous, actually, out of all of them. It's the least understood of how to do it directly. It's probably most accomplished by nurturing the microbiome, right? By giving these fibers that are producing short-chain fatty acids, which are feeding the colonocytes, the enterocytes. But there's a lot of ways to repair that barrier. And if you can't, again, you got to repair the barrier. If we can't stop this leakage from happening, then and I think that sometimes people who are on Remicade and they're still having the leakage and their immune system's just not responding to it. You know what I mean? And that's why it doesn't fundamentally address the mechanism. So we have things that might repair the barrier, like gelatinous fermentable fiber, blueberries, bananas, avocados, supplements, maybe glutamine in the small intestine, maybe butyrate. Butyrate can be toxic in too high of amounts. There was a lot of interesting data with phosphatidylcholine. They almost made it to a phase 3 trial. I think it's one of the most powerful supplements that I take. I feel a difference, and I take a very specific type of phosphatidylcholine. Let's see here. So there's a supplement called SBI Protect, serum-derived immunoglobulin. It tends to bind bacteria. That might help. Different vitamins, A, C, and D. And I'm even including things that might even just have one study behind it. We have obviously food textures. Like, that's where, even UCSF told me right away, avoid nuts and seeds. I think it's a really good recommendation. I think that if you're inflamed and you're eating a lot of nuts and seeds, you're probably ripping open the barrier a little bit too. I think like avoiding a lot of dry crackers and things like that, soft, wet foods can be really, really important. Okay, let's see here. And like just trying to take all this fiber, raw vegetables, that's probably going to be, hurting the barrier too. Avoiding super strenuous exercise. Like if you're we have a lot of overachievers in the program who will go run a marathon when they're flaring. That's not a good idea. Let's be really intentional. And I know Briggs takes a little bit of vitamin C before he exercises. I can say anecdotally, I think that works well. I can only say that anecdotally. For me, avoiding NSAIDs. I think we know that anti-TNF drugs help repair the barrier. Lifestyle, again, sleep, moderate exercise, stress mitigation, fasting. It's not, and with our adaptive dietary framework, it's not just like what foods are we taking out. It's about what foods we're putting in. It's about when we're eating. It's about how we're eating. It's about encouraging clients, hey, can you just put your fork down between bites? Slow down. You know what I mean? Don't watch YouTube while you're eating. Take 45 minutes to eat your meal. Chew it really, really well. Maybe an elemental diet. So I went through a lot of different things, you know what I mean, there. And that's only a taste, but the question is, how do we put those factors together?
Yeah.
How do they figure out all what works and what doesn't, and a little combination, the pattern of different factors like that's going to work for each individual. And every remission master plan looks different in our program. Mm-hmm. The diets look different. Supplements they're taking looks different. There's patterns, for sure. And it's not, we got to get out of the mindset of something working or not working. Like, we got to get out of this black or white mindset.
So how do you navigate having so many potential interventions? Do you usually tell people to try one thing at a time, or do you do multiple at a time? Because it may be difficult to know which one of these is working, or especially if you're taking a group of things at once. I guess what I say is it probably doesn't matter, but I guess to fill out like a document like this, it would be hard to say, oh, this is helping me versus anything else.
We're all about what's feasible, and so we have some folks who might be more inclined to just want the kitchen sink approach, because if it's working, and they'll figure out, dial it in, like which is having the most impact maybe later, but like the point is that I want to feel better now. Mm-hmm. And so in some ways, like they're like, great, let me just hit it with everything that I possibly can in all these different angles, and that does like often work.
Sometimes works.
And so I think people find us because they want to take action and they want to feel better now. And so getting them to a point where they aren't in panic mode with their condition, even just like that one step into the lifeboat, we'll call it, gives them a better perspective on then being more strategic and being more scientific and trying things one at a time.
Okay.
So it's a balance of both.
I think it's personality, too. There are just some people who we're not going to get to just try one thing at a time. You know what I mean? And maybe that's ideal. I even think I need to do that more. Michael Briggs, myself, multiple of our clients, we're like kitchen sink. Let's just throw everything at this. You know what I mean? And sometimes that's needed, you know what I mean? And if someone's really gung-ho on that, there's not much we can do to like convince them not to do that approach. We kind of just gotta go with it and support them. But we often encourage, here's what I do, is we say, what are the things that let's start with the science. What are the things that have the most science behind them? And then what are the things that we see are working best, that our members are reporting best to us? What are the things that like GI doctors or nutritionists or Allie, our science advisor, is telling us works the best? Let's try those things first as a foundation and then make small tweaks one at a time. And it is important sometimes to make small tweaks, because we see people take a supplement that works so well for other people. An example is this supplement we really like called Repair Guard. It contains a really high dose of quercetin, which is a specific flavonoid, and it's amazing. It's really powerful. one of our clients, she just didn't tolerate it. Everyone else was tolerating it. She just didn't tolerate it. And if she had thrown 5 or 6 things at it at the same time, she wouldn't have known that.
Right.
And she was able to record that in the remission master plan. So look, this is an imperfect process. The remission master plan is not perfect. We are continuing to refine what is the best way for us to help people figure out what the heck is these pattern of interventions that's going to work for them. Mm-hmm. And ultimately, we will need more than what our program is. And we'll talk about this later, but, in-person retreats and, really immersing someone in an entire environment that's going to allow them to change their brain, to be able to complete the remission master plan, and to be able to decipher what the pattern is for them as an individual.
Part of the value that we get as our community grows is that these individuals get access to a wealth of other stories in much the same way that, like, Andrew and I, in interacting with all these people, and you as a doctor, get exposed to so many different stories that we can start to see the patterns that emerge. We're able to empower our members with that same access to information through the community and through the engagement that they have with that.
Mm-hmm. Yeah, I think my enthusiasm for a lot of these supplements has waned over the years. Just on the other side of the coin, playing devil's advocate and it's hard to not get influenced, especially when you have the condition and you've tried a lot of these things. But in my case, I have tried multiple supplements, multiple over the years, even ones that had decent data behind them. Even some that had small randomized controlled trials, although most of them don't have very high quality data behind them. You can say maybe because they didn't have pharmaceutical money backing them, but ultimately I didn't feel like any of them worked, and I really hoped that they would. For example, things like boswellia, curcumin. I mean, so many I've tried over the years. Bee propolis, manuka honey. I mean, I have like a whole drawer full of this, cinnamon capsules.
Well, it's so tricky when also the variation that can exist even between things that are called the same thing but between different brands, or you buy them in different locations.
Yeah, you never know what's in them.
Exactly.
And the thing about probiotics is I don't prescribe them most of the time. I actually experimented with Visbiome recently, and I didn't notice that didn't do. I mean, I feel like people get a little bit of a benefit over the course of a couple days, like they feel a little better, then it kind of wanes.
I just don't think that supplements work like medications. They don't work. They're not like, is this working? I know this is really frustrating to hear, but it's like they are supplements. Like, they are there to like poke the little cytokines slowly in the right direction, and there's a combination, and I would encourage you to like really dive deeper in the brands. We've gone through methodically to see which brands. Like, for example, there's a difference between all curcumin is not created equal.
Well, I tried Theracumin. I think you had recommended that one. That I think I did that for a solid 3 months, I think, and didn't notice, like, one capsule in the morning, one capsule at night. I don't know if the dosing may be different, but I tried that one. Mm-hmm. And I know you said a lot of people in your program feel like they feel good on that. Right?
And it's not like, again, like when someone takes prednisone, it's like, for someone who really responds, it's like night and day.
Yeah.
Okay. Like, just supplements and herbs don't work in that way, and I think they're probably the least important intervention. And there are multiple members who don't take a lot of supplements and herbs, and every time I'm feeling better, I'm always decreasing my dose of them.
Yeah.
But and look, do I know with 100% certainty, Samir, that every single one of my supplements is making a difference? I don't.
Yeah.
I don't.
Yeah.
And that's okay. I know that these come from reputable brands that have been third-party tested. Mm-hmm. I know that they contain what they say. I know that there's not maltodextrin or polysorbate 80 or carrageenan or any of these different compounds and titanium dioxide, whatever, all these binders and additives that are in there. And there's obviously not enough evidence, but like, we got to get out of this mindset right now of just, does it work or not? And I know that's a little ambiguous, but I think you kind of know what I mean, of just like, it is part of this whole approach. And would that theracumin have worked better in combination with another variable? Was there something else going on? Was there another contextual factor? Or maybe theracumin for your biology is not advantageous for you? Sure.
Yeah, I mean, as playing devil's advocate to that, I mean, if you're on a medicine that works well for you, in the absence of using any supplements, I guess you would argue that maybe these supplements would lead to more complete healing to the point where maybe you could get off medicine. And certainly that's something that needs more investigation and study. But for me personally, I think I do well on medicine and diet. That's what I've been kind of preaching. I think those are the most powerful things. And as far as supplements for me that I use now, I just use vitamin D. That's pretty much all I do besides the medication and diet. So.
Well, yeah, and we know that ultimately it would be really great to be getting a lot of these compounds from our food. It's a shame that there's not enough nutritional density in a lot of the food that we have available to us. That then they get sold in these little encapsulated processed forms. But ultimately. That would be the most ideal format to be taking these.
Samir, is it possible? Is there a small possibility that these supplements are doing nothing for me and that it's a totally placebo effect? Yes.
That's okay.
And I'm the first person to admit that. You know what I mean? Yeah. I don't think that's true. I really don't. And if I fully thought that, it wouldn't help. You know what I mean? Yeah. So the patient, the human being, you do have to kind of believe in what you're doing. Sure. And this, but I have a very severe disease. I told you, we haven't gone through my story. It's extraordinary that I'm not on a biologic right now, and I'm not really willing to gamble, you know what I mean, that way and just sort of, stop them. I think I do probably fine. I agree with you 100% that diet and meds are the most powerful interventions that we have. Yeah. And I actually want to say, just moving on a little bit, I think for a majority of patients, the most powerful tool that we have actually in stopping the inflammation is prednisone. And I think prednisone gets this really bad rap, you know what I mean, for really understandable reasons, because it causes so many side effects. Patients feel really good on it or they feel terrible on it, you know what I mean? They can't sleep, it pulls stuff out of the bones, you know what I mean? We know all of the side effects. Ali Arjman in our group, he always has a little bit of prednisone on him, and this is his style. He doesn't take as many supplements. He's very into diet. The second he feels anything, 20 milligrams of prednisone for 2 days, and that's it. And it's just enough to stop it. So what we're seeing is that, again, I'm just telling you, we're not making recommendations to patients. We never do that. I'm observing how they're interacting with their GI doctors. The patients who go on these long courses of prednisone, they don't do well. Right. When it's short and aggressive, you know what I mean? And it's just enough to stop the inflammation and then allow diet and lifestyle to work. It's incredible sometimes. And there is a subset of patients, maybe 5%, maybe 10%, that don't respond to prednisone, that they respond to a biologic. So personally, what you saw in my remission master plan, that if I was feeling something, I probably don't go to prednisone right away. I go to budesonide, and I use maybe 4 days, and it's just enough, you know what I mean, to put things back on course. But maybe if I wasn't using the supplements, if I wasn't practicing a dietary style, if I didn't take time away from work and stress and all those things, that wouldn't be powerful enough for the steroid to do that. There are a couple studies Lucy found, and it's not strong evidence, that steroids disrupt the barrier, that there's a barrier disruption. I think Briggs and you might have talked about that. And that would make sense for why people go downhill on prednisone so much. what we find sometimes is that people can do like a really short, and sometimes why we find this out is just people just experiment and people do whatever they want, and then they report to us and they tell us what they do. And so the best we can do is record that data and report, what we're hearing from people, and we understand the limitations of that type of evidence. But what we see kind of over and over again is that people do a short, aggressive course of prednisone, especially when they're already in remission right there, and then they actually don't feel better till about 3 days or 4 days after the prednisone. And I noticed the exact same thing. Well, if I use Butest, like say that I'm doing super well and that I explore a little bit on my diet and I let things get a little, I'm a human being, I do that, and let's say that I feel like a little nausea, or I feel I get a mild fever. That's one of my telltale signs. Actually, one of my weird telltale signs is that I can feel my pulse in my belly button. Like I have all these weird things that I recognize, like what the heck, I know when my Crohn's it's almost like a internal calprotect, and I'm like, I bet my calprotect went up a little bit.
Sure.
I'll hit it with a little budesonide, maybe a little prednisone for 3 or 4 days. I don't feel better while I'm on the medication at all. It doesn't work. And then 3 days after it, every single time, or 4 days, I'm better.
Oh, interesting. Okay.
And I'm really going out in the theoretical here, so forgive me. I try and be the best scientist I can, but my hypothesis is that there is some sort of barrier disruption that occurs from the prednisone, or the budesonide. There's a little bit of data to support that there's some sort of barrier disruption that's happening right there, and then when it stopped the inflammation enough that allows enough time for the barrier to hopefully repair that time.
Yeah. No, I mean, I think if you can get by doing that, I mean, the side effect profile of a few days of even prednisone or even less so budesonide is negligible. So if that can keep you going, at least symptomatically, that's great. I mean, there are some patients where a few doses of prednisone does not work, and they need longer course. We usually give 2 weeks before we say it's either working or not. But yeah, maybe.
But what if that's a mistake? Like, what if they need to actually stop the prednisone? Like, what if they actually need to stop the prednisone and they need that foundational lifestyle to even determine if it's working or not? Again, we're playing devil's advocate with each other.
Yeah, it's hard to know. I mean, it's an interesting idea to see.
What do you think would happen if we used? This is just, again, theoretically, we're shooting in the dark here a little bit. But what do you think would happen? What do you think would happen if, instead of doing this like traditional taper of prednisone, it was used in a way where there was 40 milligrams for a week, and then there was a week off, and then another 40 milligrams for a week, and then a week off, or something like that. I wonder that's even kind of a high dose, maybe even less than that. I wonder what would happen. I don't think that's ever been studied, and if there's any, there's probably no motivation to study that because there's not any financial benefit to prednisone. But let's not demonize anything. Let's not demonize anti-TNF drugs. Let's not demonize prednisone. Let's not demonize any tool that we have. Let's think about creative ways that we can use them that minimize damage.
Yeah, I think theoretically, steroids decrease protein synthesis, and that may be could be responsible for. Steroids don't lead to mucosal healing for the most part. I mean, there are certain trials that have shown mucosal healing. I think there is one for UCERIS, budesonide MMX, looking at ulcerative colitis. I think it's the Pursuit SC trial, which looked at mucosal healing, and they did see it. They did see mucosal healing, at least a certain amount of the patients with that intervention. But for the most part, we don't see mucosal healing. It's not thought to be something that heals the colon up most of the time. I think doing that type of steroid course, a week on, week off, certainly could be studied. But yeah, I've never really thought of that. I don't think that's on anybody's radar. Maybe,
I'll send you Lucy. I talked to Lucy about my hypothesis, and she went down what she calls a PubMed rabbit hole, and she collected all the data on how steroids may disrupt the barrier. So I'll send that to you.
But this is what needs to happen. It's like, I feel like people who have the disease are the ones that should come up with research ideas, because we're the ones that are noticing these things, And if you're noticing that, and your cohort of clients have been noticing similar things, yeah, I'd be happy to collaborate with you on a study on that.
Yeah, and I'd be happy to be proven wrong. I love, I'm more than happy, and we just got to try things, and we got to figure out how we can align. I mean, this comes back to aligning these huge financial incentives and things like this. How do we study things that aren't, gonna like produce this like huge, financial profit? No one's going to study prednisone. There's no money to be made with that, right?
I mean, with prednisone, I've been trying to transition away from using it, especially in Crohn's disease. I offer all my Crohn's disease patients the option of exclusive enteral nutrition rather than prednisone, no matter what, because it's actually pretty cheap. I know we had a discussion on this on the Facebook group, but I use Ensure Plus mainly because it's affordable, easily attainable, still works despite all the crappy ingredients in it, but still tends to work. For some people, they don't tolerate it well, but in my experience, it works pretty well. And I even had a patient who didn't respond to pretty much all the biologics and was facing surgery, ultimately did get surgery, and now she's doing fine on exclusive enteral nutrition. She's staying on her meds. And then I have another patient who is facing surgery, about to get her second ileal resection for stricturing Crohn's, and has pretty much escaped that fate by drinking Ensure about 5 days a week.
And it's funny, is you told me that Kate Farms didn't work for you, and I was pretty excited about it. I was looking at it, I was like, this tastes really good. I felt like crap on the Kate Farms.
Yeah,
it theoretically should have worked, and I felt terrible on it.
It tastes bad. Like it's
really? I like the taste of it. I think it tastes pretty good.
I know there's some sort of like metallic aftertaste to it. Some of my patients love it, but I tried it and it didn't.
I actually emailed them and I said, my again, I always have these hypotheses about what's doing. There's like rice syrup. What if they substituted that with honey? It's SCE compliant. What if they took the sunflower oil out of it, which is high in omega-6?
Right.
What if they change those two ingredients? That might be it, because I don't eat any sweetener besides honey.
Right. Yeah, and then there's, are you familiar with Ginny Patel Thompson?
Of course, yeah.
Like she's, I guess, one of the pioneers of this kind of like alternative movement. But she had Absorb Plus, and I know we got into a discussion about that, about maltodextrin. And, she had some rationale for including it.
I just can't. I cannot consume any. Maybe it's just my mindset. Maybe it's placebo around it. If I know that there's a binder or additive in there, I absolutely just can't consume it.
Well, a personality trait that we see among our member base is a tendency toward, like, perfectionism is a tendency toward being an overdoer, we'll say. And so a lot of our coaching includes, like, helping them back off from, like, there's so much that you can do. You'll never do it all, and that's okay. So, like, pick the lesser of the two evils. If it's working, if it's feasible for, if that's within your budget, or your emotional budget, even.
Yeah. So, if you're okay with that, can we talk about this? The procedure you had for your fistula.
Wow,
this is interesting. Okay.
Yeah. So this is a really crazy story. Last time we were on the podcast together 2 years ago, I had an active anal fistula, which was a complication from my Crohn's disease that my colorectal surgeon at UCSF just really didn't want to touch. I really respect her for that. She's like, Andrew, you're doing so well. You're in remission. I don't want to do anything. The outcomes are not good with this procedure. So that's actually how I was diagnosed. I developed this fistula, and I had it for 14 years. So even though I was in remission, even though I started IBDCoach, I still had it, and it made things very difficult. Fecal matter. So anyone who's listening who has a queasy stomach, fast forward here. But like, fecal matter is always going through that little passageway. It was pretty controlled. I can't even tell you how many procedures I have for Seton placements. Initially there was a failed Cook plug procedure that was done.
Right.
And I got to a point where I asked her to just fix it, to just do it. And I'd wake up and she'd be like, I decided not to. Like, no.
Clean it out.
She's like, I cleaned it out. I think it's healing. I'm like, no, please.
What was your experience with the plug? Like,
it failed immediately. It's like, again, they tried to just fix it without my Crohn's being under control. My Crohn's was out of control. Like, what do you think's going to happen? And that was right when I was diagnosed.
Okay.
So I think shortly before our podcast, I told you that I had this idea to go to India. And the reason why is I started talking to people, and I found out about this procedure in Ayurvedic medicine. And I don't know that much about Ayurvedic medicine. I try and be very evidence-based. I don't consider what we are doing actually complementary. I consider it to be science-based. Like, that's really important to me. I know there's a lot of concepts in Ayurveda that are just kind of like not science-based. And so that was kind of my breadth of knowledge about it. So I was very skeptical. It's called Ksharsutra. It's a procedure that has been documented for thousands of years. Like, what? It's crazy to hear about. And it's a procedure that there's multiple problems down in the anus, that hemorrhoids and different things that can be used. So let's talk about, just, you might want to, if you're listening to this podcast right now, you might want to type in anal fistula right now and just look at a little picture, a little diagram to understand this. What happens in Crohn's, right, is there's an infection, and that infection has to go somewhere, and there's a passageway between the rectum, usually, or between a little bit higher up, and it exits some part of the body, right? So for me, it exited my perineum. You can type that in for those who don't know where that area is. So these fistulas are really tricky to heal. They're very difficult. The surgical outcomes are bad because the anal sphincter muscle is right there, and in order to lay them flat, people become incontinent. They're a very tricky problem, and my colon rectal surgeon, she didn't want to touch it. She just was like, I don't, she really, and so it was always just the fact that I kind of accepted that I was just going to have this Seton in for the rest of my life, and I was always going to have drainage, and that every time I had a bowel movement, it was going to be uncomfortable, and that I constantly had to be near a bathtub. Even though I was doing really well with my Crohn's, it never healed. So the way that this procedure, so there's different ways that they've used to heal. There's a plug. They try and plug it sometimes. Other times they use what's called a cutting Seton, right, where they use a metal thing and they get it closer. There's different flaps that they use. There's a lot of, and you can speak to this more.
Yeah.
The way that this procedure works, it's that it's done over time, and it's done over the period of several weeks or several months, and it uses these herbal-coated threads that are coated in cauterizing herbs. One of them is turmeric, and a couple other ones that I actually can't pronounce right now. And they are tightened very slowly through the fistula and then through the anus, and they are tightened very, very slowly. And you slowly cut through the anal sphincter muscle, and you merge the fistula tract with the anus, and it becomes one, and then it heals. And because you're cutting so slowly through the anal sphincter muscle, it heals from behind. Mm. So I told you I was going to go to India. That was my plan. Yeah. My plan was to go to India, and I researched it. I looked into it. And I started to get really into it. And this was kind of right before COVID was happening. Mm-hmm. And I just had this, as I was researching, I said, how hard could this be? Yeah. And I just want to warn you, if you tried this, it probably won't work. It was the most extreme, sort of reckless thing I've ever done. It worked. Okay, I'm going to take that away. I sort of did it because I wanted to prove a point that this was ridiculous, that's not available in the United States. Yeah. This procedure has a 98% success rate in India. It's well acknowledged that it does. Thousands and thousands of people have gone to India to these Ayurvedic surgeons who they operate in modern surgical suites. They use antibiotics. They use modern outpatient. It's an outpatient procedure, but it's not done in our system because it would require a huge cost from insurance companies, right, for people to go in and do these thread changes. So what I did is I said, what if we could do this here? Would there be a team that I could put together that we could do this? I'm the type that is okay with experimenting on myself. I'm a little bit like Michael Briggs in that, in that way. And so I befriended an Ayurvedic surgeon. He was a really nice guy. I told him what I wanted to do. I think he was a little skeptical at first, but I befriended him. I spoke with him, and he said, you can give it a try. It's not gonna be anything harmful. If you get an infection or something like that, you can take antibiotics and you'll be okay. He sent me the threads from India.
Okay.
And when they arrived, they're like these yellow, crusty threads, and I assembled we studied this procedure. Amy and I studied this procedure. I enlisted the help of a naturopathic doctor who was willing to do this with me and supervise us. I enlisted a friend who's a medical student. Again, I want to say, like, I recommend that if you have a fistula, please go to India. Please have this done.
Kids don't try this at home.
Kids don't try this at home. Like, please don't try this at home. It was intense. Okay, it was the most intense thing I'd ever done. My dad, who's a physician, was like, Andrew, please don't do this. Please go to India. Please have this done. And I said, Dad, I'm not ready to go to India right now. I want to go to India one day. I'm just not ready to go there. My diet is so good. I'm not ready yet, and this is what I'm going to try. So everyone got on board with me. Amy, who has taught, sixth grade science, she typed up an entire lab report of how we were going to do this. And we decided to have a meeting about it and plan it out. And then my naturopathic doctor, being the kind of person, she said, let's just do it. Let's just put in the first thread. I'm like, okay. And so I had a Seton placed specifically to do it. And we used the Seton to pull through the first thread.
Okay.
And Amy is an expert at tying knots. We asked this doctor exactly how to do it. We watched a bunch of videos and how to do it. And there it was. We put in the first thread and we tightened it pretty tight. And even the first thread, we saw a little bit of cutting occur. And this, for me, I think my fistula was a little bit higher up. And also we probably had a couple mess ups here in what we were doing. We did this in my house. We did this in a very sterile environment. We had all of those practices done. We actually used one product called Yin Care, which is a Chinese herbal product that does have a lot of scientific evidence. It's highly antimicrobial. We used a lot of that. I took a lot of baths while I was doing it. And every couple days, every week, probably on average every week, we would do another thread change. And it was extremely painful. It was like, it was probably one of them. I screamed, during this procedure.
So with each thread change, was it tighter and tighter, or?
Yeah, and so we eventually, we could see every time we cut a new thread and take the old one out, yep, that's the loop, and the loops kept getting smaller and smaller.
Okay.
His fistula ended up traveling a solid 2 inches to meet the anus, and and then also come to the surface from behind as well. And so we would do a thread change just about at the point where it was no longer painful for him. So that's there's some sort of surface healing, and we would catch it right at the point to balance the. Well, it's going to hurt pulling it through. The needle hurt less if it's slightly healed, but try to keep the momentum of the cutting and the healing.
And I thought about how I wanted to talk about this, and I just said, I'm just going to be honest. I'm not going to pretend I was in some sort of clinic. I'm going to be honest. Sure. I'm going to say that there were risks, to doing this. Yeah. Please don't do this. We almost failed a couple times. There were a couple times where we messed up and we lost the Ksharsutra thread, so there's nothing in the fistula. And what do you do? Yeah. Well, actually what you do is you get an infant catheter and you fold it and you stick it back through the fistula and you loop and you pull the Ksharsutra thread full, and think this is a crusty, dry thread. And
it was doubled over.
10 out of 10 pain. That is that is the pain. But I was so determined, you know what I mean, to do this. And I think I wanted to kind of just prove a point that modern medicine will ignore the data, that they'll just ignore a procedure that is effective. And I wanted to just kind of show that I could do it. But I was also really motivated because this thing sucked. I wanted this thing to go away,
It significantly limited our travel. Even the trip that we took to Chicago 2 years ago looked a lot different in terms of getting Andrew's needs met.
And I didn't talk about it. I didn't really talk about it. It's not something that I really brought up. It's embarrassing. 20 thread changes. It shouldn't have taken that many thread changes. I think they would probably, if they were doing it in India, they probably would have done 10. It took us 20. every week it took us 3.5 months. I budgeted only a month and a half. I thought it was only going to be a month and a half. It took us 3.5 months. And by, about halfway through it, we're like, this is working.
Yeah.
This is crazy. We documented, we have pictures of all of it. I told you about it.
Right.
And I remember the day that we broke through. Amy and I were together. She cut the last little bit right in our living room, and I cried. It was just like, I can't believe this thing is gone. I had a little wound right there, but we just packed it. Actually, the wound was much smaller than it is usually there because we went so much more slowly. They usually just go like real fast, through it.
The last little bit of skin was like, 2 millimeters?
Yeah, 2 millimeters, 2 millimeters. And it was, I just want to say, like, it was very difficult for Amy she did a lot of these thread changes on me, and she's my wife. She's someone who loves me. It was very difficult for her to hurt me.
Right.
This is a crazy story, and like, we realize how crazy this is, but sometimes this is what people are willing to do, in order for their health.
Yeah.
And and then COVID hit, so it wouldn't have even been a good idea to go to India. It would have been stuck. It wouldn't have even made sense. It's healed. It's completely healed. I have normal. I almost forget that it's there.
So no issues with incontinence.
No issues.
Everything's fine.
Everything.
And did your surgeons take a look at it too?
They haven't looked. She hasn't looked at it yet. I sent her all the pictures. I spoke with her. She was blown away. She was absolutely. She was, absolutely blown away. And I think hopefully she's really open, and maybe she would be willing, we could one day work to bring this procedure here, so patients would have access to it in the United States.
And I know you guys have been working on trying to publish this as a case report. Is your surgeon interested in being on the paper?
Oh, I doubt it. I don't think so. I'm not going to ask her that. Yeah,
you should ask her. I mean, maybe it would give more credence to it.
It would.
If she could examine you and confirm it.
I think, to be honest with you, I think I'm just so happy it's gone right now, and I'm so and I don't think I think we will publish it. We will get around to it. We've been obviously very busy with our program and our company and making sure that our clients are okay and doing well. But we've had several clients have multiple. There's a client, she has a vaginal fistula that you can use this technique with a vaginal fistula, and she's had 2 failed procedures now. That don't. The techniques that we have with fistulas, they don't work very well.
So did the Ayurvedic practitioners who you were in contact with, did they say they've used this specifically for Crohn's fistulas? Because people can develop fistulas, they're called cryptoglandular fistulas that have nothing to do with Crohn's. So I'm wondering if their experience was mostly with those type of fistulas. And Crohn's is pretty common in India now, so they may have experience with it. But what did they say? Did they distinguish
my understanding, it's about half and half. The people with Crohn's and half the people who don't have Crohn's, and they do. Some of the surgeons reject some of the Crohn's patients, because they just are like, it's too much. It's not gonna work.
Yeah,
but it's expensive. I think I calculated that this would have cost about $10,000 to do this. Even
and you'd have to stay there for a whole month,
or even longer. They've done fistulas. Okay, they did this fistula where this guy was running. This fistula was running all the way down this guy's leg. Okay, like all the way, just. And they, over the course of 7 or 8 months, they just slowly used the threads, and they just brought it closer and closer and closer and closer.
Yeah, maybe it is this just taking time with it, because the colorectal surgeons they used to treat fistulas with cutting setons, but I think most of them have abandoned that approach because there was a high rate of fecal incontinence with doing it that way. So now really the standard of care with perianal disease and Crohn's is kind of this combined modality of usually anti-TNFs in like Remicade, Humira, in addition to Seton, sometimes with antibiotics as well. And then, even that approach is not that effective in most patients. Most patients don't heal the fistulas. Most patients have to keep the Seton in for long periods of time. An attempt can be made to take it out, but and some people are okay, but some people have recurrence and they have to have a Seton in more long term. And sometimes they do surgical procedures to address these fistulas if they're relatively simple, traversing a short distance. And they will do something like a fistulotomy, especially if the Crohn's is controlled, particularly in the rectum with medicine. But yeah, your experience with this, what's unique about it is how much time they took. They're very slowly doing it over time. Yeah.
I mean, we could feel the difference between when we were working through, say, skin and muscle tissue. When we hit that anal sphincter muscle that is like so dense, the threads would not move as quickly, and so you could feel it. And then once it had passed through, just noticing that it's basically just skin at this point, and we're just cranking it down. And so that ability to like really tune into where are we in Andrew's body, and where are we headed, and what's going on, and to just take it a baby step at a time, really makes a huge difference. To be able to respond, we slowed down when things were very, very painful for him. We could accelerate when we're moving through more surface tissue.
Right.
I asked my colon rectal surgeon about this, and she's like, look, I can't really comment on this. Okay?
Yeah.
She's like, I can't really, but we've seen some really positive results from RP who failed us, and they've gone to India.
Oh, really? Okay.
Yeah, they knew about this, and so it's like, it gets back to the crux of IBD. It gets back to the crux. We have tools that we can use. And this is like, I think this is so blatant because it's physical. It's a physical procedure. You can see as clear as day that I had a fistula before and I don't have it anymore. What happened,
Yeah.
So it's like, why are we ignoring this? Like, it's infuriating to me, too. Why did I have to live with this for 14 years? I had multiple infections because there's so many times where it would heal over. I'd be surfing and it would fall out, and then I have to go back to and they wouldn't even just I was like, can you just put it in? Can you just put in a Seton without sedating me? They're like, no, sorry, we have to sedate you.
Yeah.
And it's just the backwards way that we do things. Every time they put a Seton in, I looked how much it cost. It was like $30,000 or something. Or it was just like, what?
Making money off
$30,000 to just stick the Seton in? Are you kidding me? Like, it blows my mind. You know what I mean? Of the backward that we will ignore. And let's get back to Bateson's quote: like, the major problems in the world are the result of the difference between the way nature works and the way people think.
Yeah.
This is a procedure that is more in line with the way biology heals, and why are we ignoring it, and it is what it is. And I hope that we can bring this procedure, we on our many list of projects that we would like to do, I hope we can bring this procedure to the United States. I hope we can bring some of these Ayurvedic practitioners. We will get our thing published. It's going to happen. And I hope that this is also kind of a metaphor for what's possible when a patient takes ownership of their disease. And I kind of wanted to show my clients that I'm not just talking anymore. I'm walking my talk too.
Yeah.
And I want to show the extreme. I wanted to really show them that I can even heal this in lifetime with you. We're healing together.
Right. Yeah, I mean, I have a lot of respect for people who, walk the walk, and I do the same thing, whatever I'm preaching, medication, diet, I'm doing the same thing. I've been on most of the medications that have been out there, so great. As far as the fistula, it's encouraging, your experience with it. Of course, part of the reason medicine doesn't, jump on these is, there are political reasons. There are reasons that probably have to do with money, but also data. It's just we need, as soon as a randomized controlled trial comes out about it, or even something as just like a case series at the very least.
Unbelievable. There's thousands of people that have healed. Thousands, tens of thousands of people that have benefited from this procedure. But look, the FDA is not going to approve these threads are like blessed by these Ayurvedic practitioners. They're laid out in the sun. You know what I mean? And like what you could see happening is that Western medicine is going to take this and they're going to take out all the full plants and they're going to find the molecules. and they're going to try and do it in a Western way, and maybe it'll work, but maybe it won't work as well. The FDA is never going to allow some threads that have been laying out in the sun in India to be, are you kidding me? Right. But we need to, I think, what if COVID, around this, what if it creates some humility, us, and to just respect that this procedure has been documented for thousands of years. That's why we're attending the Ancestral Health Conference, that we truly believe that, our ancestors didn't have IBD. IBD was non-existent. So there's some disconnect between the way we are living our lives. And IBD, Samir, is a sign. It's a signal. It's that when you develop IBD, it's a wake-up call, and it says, hey, there's something that's going on in your body, there's something that's going on in your life, and it's an invitation to engage and correct it. Let's say that Haley, who I talked about, let's say that she had never developed IBD. She is a way healthier person because of her IBD diagnosis. I am a much healthier person because I can run faster than my friends. I eat better than them. I feel better than them. Yeah. This has been, IBD has been the greatest opportunity of my life. Right. You know what I mean? It's defined my career, and how can we make remission and IBD a way of life for people?
Now that is an unrecognized thing, that although it's a diagnosis that, is obviously not what people want to hear, but it is an opportunity to completely change your health status. And even for me, I've been pretty much haven't eaten processed food for over a decade now, and I regularly exercise and meditate, all that stuff. And the first thing patients say to me when I walk in the room, they can't believe I'm a doctor. They're like, oh, you're too young to be a doctor, despite me being in practice now for almost 4 years. And being 36 years old. And I asked them, how old do you think I am? And they routinely say at least 10 years younger than I am. So, and I really do think that has to do with diet and diet and exercise and all that stuff. So I would probably be less healthy if I wasn't diagnosed, because I would have just continued eating the way I was before.
Yeah. I want to say, look, our program right now, we have a big vision, okay? And what I consider what we do as the kind of initial conditions to a massive change. And maybe we'll get there and maybe we won't. But the fact is that there are some clients that need more than a digital program that what we offer. And our vision is to build centers, to build retreat centers that fully integrate with the Western healthcare system, where, let's say that a patient is diagnosed with IBD, they're stabilized, they're given either biologics or they're given steroids, and then right after that, their whole family, or whoever they want to bring, we take them to a safe, beautiful place, okay? Covered by insurance. I know this is it's going to be, let's just dream for a second. Let's just imagine that this is covered, by a world government, if there's somewhere else besides the United States, or it's covered by insurance, and we immerse this person. They're suffering from PTSD from their diagnosis. We give them love, compassion. They're with other people that are there. They're in nature. Okay, they're able to experience these beautiful things. We show them how to cook their foods. We educate. We teach them biology. Right then and there, we show them how the remission master plan works. All of these things, that are right there. And then when they leave, maybe they're there for 2 weeks or something like that, we're still with them in a digital way, just like there, but they've taken all of these lessons. Their brain has changed, in some type of way, and they are well equipped now to handle. They're in a completely different mindset, to do that. And that's our vision with IBD. And frankly, we believe that this can be applied to almost every condition, every chronic health condition, and that this is an enormous missing part. And at the end of the day, if there's any insurance brokers or insurance people who are listening to this, we believe that insurance companies can make money doing this too. Everyone can make money doing this. Haley and Nikki and all of these other people that are in our program, we've calculated that we've saved their insurance companies hundreds of thousands of dollars just in what we've done. We have saved you money.
Sure.
So we just our next step is to really publish data, to track all of our clients, to see that make sure that people are engaging with our program, making sure that their calprotectin is going down. It's huge reductions in calprotectin. We've had clients who have had a calprotectin over 8,000. It's now 250, not on meds. It's unbelievable. Using prednisone was needed. Obviously, medications were needed to get there, but just the whole mindset change has been absolutely unbelievable, and that everyone can win here. It is a win-win. I even think, and we are not anti-pharmaceutical drugs. Pharmaceutical drug manufacturers will continue to make money. Insurance companies will continue to make money, and patients can have better outcomes, and we can have happier, healthy human society.
Great, yeah, and I would just add one more thing as my comment regarding that. And I wish you the success in this endeavor. Hopefully it works out. Again, just to reiterate, we have no financial relationships. This is all completely objective. I'm just interviewing you as a curious party as far as what you're doing. But if I needed advice for you as far as getting this more into the mainstream, is insurance companies, they are very data-driven people. Even when I try to do things like adjust doses of medications, like Biologics, increase the dose, or get certain things approved, they'll come back at me and say, show me the data. And oftentimes I do, and they do change their decision. So what I can foresee leading to that path is a randomized controlled trial where you have two arms. One arm is standard of care, medications, biologics, whatever the GI doctor wants to do to treat the IBD. And the other arm is also that medication standard of care plus what you're offering on top of it, and seeing if the outcomes are different. And if they are, that's a hard study to do, but actually practically it's not that hard because, you'd have to get funding, but it's all done remotely, right? Your program, people don't have to travel to see you. It's all done remotely. So really, it's just setting these patients up with you. And if someone out there is willing to fund this study or see if it would make a difference, and if with hard outcome measures such as colonoscopy, calprotectin, CRP, in addition to symptoms, if we do see a difference, the insurance companies cannot say no.
And I think in a couple of years we will be ready to do that study. Okay. What I want to make sure, we do have a level of humility around what we're doing, and we do have a level of this is a completely new approach. What we're doing, we don't make recommendations. This is bizarre. People, they get into our program, they're like, well, what do you mean you're not going to tell me what to do? Yeah. No, I'm not going to tell you what to do. And that's weird for people when they first, you can speak to that a little bit.
Yeah, it's disarming because so often in the medical system, people come to us with that experience of, okay, the doctor's going to tell me this, my nutritionist is going to tell me this, and so what we're really trying to cultivate is that internal agency, and so to help individuals be active participants in their own healing process. And so we don't make recommendations, but we do empower people with the information to make choices for themselves in collaboration with their medical team, because IBD is so individualized. There's no possible way that I could know what's best for a person or that Andrew could know, or even but the person, in cultivating an internal sense of what feels good, what works and what doesn't, can know themselves best and use that information to the best of their ability to.
And I want to say, if there's something a patient wants to do or they learn something in our program and we're sharing that person or something, and you say no, it's a no. It's a no. And that's important. But that no needs to come with an explanation. You know what I mean? And they need to understand why. And we help them when their doctor says no to something. We actually help them understand why their doctor said no. Yeah. To them, when their doctor is recommending biologics, we help them understand why it's important. To take a biologic and why that might help them. And if it's not working and there's a huge incongruence with their physician, then maybe they find another physician and we help them. With that process.
Right. Great. Anything? Should we wrap this up? Anything else?
It's been an amazing conversation. I'm just very grateful to be here, to be in collaboration with you. I just, the reception. I thought the reception from mainstream GIs was going to be pretty mixed. I'm still sort of waiting for any negative, reaction. It hasn't happened yet. We've talked to so many mainstream doctors, even doctors that don't historically have believed in diet. They're looking at us, and I think they're relieved that there is a program like this that is going to educate their patients about diet, and educate them in this way. And yeah, I think the last thing that I, want to say, and if you want to say anything lastly, is just let's take a step back. Chronic health conditions are spiraling out of control. And like the big crises that we're facing in the world, whether it's global warming, whether it's, financial instability, whether it's, this is a crisis that is coming and no one's talking about it and no one's noticing about it. And before we know it, it's going to sneak up on us. And the rates of IBD are going up every year. We need this right now. And, we have a grandiose vision. We don't pretend that we're going to be able to do it overnight. We think it's going to take a lot of time, and we're going to keep trying. And we always say, look, let's shoot for the stars. And if we get 5 or 10% the way there, we've changed the world, so.
Yeah. It's just been such a pleasure to be here and get to speak about our work. And it's really feels special what we're doing every day, so I'm really happy to share it with everyone.
Yeah, and thank you for doing what you do every day, Samir, and we're glad that you haven't recorded a podcast in a while, and I hope you get back into the swing of it, because people love your podcast. Our clients love you, and they love your podcast. And just the fact that you have IBD, and that you're able to communicate with them in that way is really, really beautiful, so thank you.
Well, yeah, thank you. I appreciate you guys coming down. Maybe we'll do this in another 2 years, see what the update is. I probably will do more. It's just, and I know I get a lot of patients on the Facebook group suggesting different guests. I'm still waiting for something I have to be interested in something. So if I think something has some promise to actually making a difference, then I'll go forward with interviewing that person. But I'm still waiting for that next topic that I'm interested in. I might do one on PTSD coming up, but yeah. Okay. All right. Thanks, guys. Yeah, sure.